valgus and varus loading to test the collaterals. Okay, what about the cruciates? Anterior drawer and posterior drawer, and then the Lachmans. Now, before I do those, though, I like to do the sag test, look for the sag sign. So I would just leave them like this for a minute, or if I was in a hurry, I would say, contract your hamstrings for me, please, okay, and then relax. And if he had a torn PCL, I would see a posterior displacement of the... You'll be able to sleep soon. Quarter's almost over. Okay?
That was a posterior displacement, I'm sorry.
Okay. It's slippery up there. If you had a torn PCL, the tibia might slip back. Just gravity might do that, or if I contract the hamstrings, that might do it. Okay, after I do that, I would palpate both sides, make sure that they both feel aligned in a neutral position, and then I can do the anterior drawer. I'm going to push with my thumbs on his condyles, pull with my fingers on his gastrocs, on his tibia. So, is this okay? Okay, I'm going to pull. And you pull until the pelvis displaces a little bit. And what do you find? Pain and/or laxity. Maybe it's not complete laxity, but an altered end feel. It's not springy. So if you have a moderate sprain, it's not going to feel empty. It might feel a little looser than the other side, but it's not empty end feel. So you need to distinguish between mild, moderate, and severe sprains on the basis of the feel. So a mild sprain, you should have no significant change in the feel. Moderate, some, but it's still catching, it's still intact. And complete tear of the ligament, empty end feel, feels gross. Okay, while I'm here doing the anterior drawer, I can also do the posterior drawer. So I push back the thanars again until they move a little bit on the table, and that would test what? PCL. So anterior drawer is for the ACL, posterior drawer for the PCL. Sag sign, PCL. Okay, so I have one left for the anterior cruciate, which is Lachman's. The best way to do Lachman's is the same method for the collaterals, except now I'm going to try to pull straight towards the ceiling. I'm pushing down on the condyles with my thumbs. I'm pulling straight through my shoulders towards the ceiling until I pull them off the table. Okay, so Lachman's test is necessary when you're assessing ACL, because when you're in this position, the anterior drawer test, the hamstrings can give you a false negative. And that's not BS. I've seen two of these, in my office, so it's like crazy. It's a bummer to tell somebody who's already been examined by somebody else that, oh, they have a torn ACL. Because the doc who examined them only did the anterior drawer, did not do Lachman's test, and therefore it's a false negative. Yeah?
What was the name of the test? The one that you did like 3 tests ago?
Valgus varus stress.
Before that one.
Sag sign. Anterior drawer, posterior drawer.
Before that one.
That was it.
Oh, the one where you had him lift up his foot.
Oh, that was for that was Clark's test, the patellofemoral grinding test. That was yes, that was for patellofemoral pain syndrome. Yes.
Anterior drawer is ACL, posterior PCL.
Yeah.
Lachman's.
ACL.
Same ACL. Anterior cruciate.
ACL. Lachman's is for the ACL. There are 3 different strands of the ACL. So theoretically, you could tear one of them and it'd be more symptomatic in Lachman's versus anterior drawer. But there are only 2. I'm only showing you 2 for the ACL, anterior drawer and Lachman's. Yes? McMurray's click test didn't get there yet. Okay, so for patellofemoral pain syndrome, we've got, to review what I did so far on the knee, we have the apprehension test, the patellofemoral grinding test, looking at the Q angle. For ligamentous lesions, we have valgus and varus stress for the MCL and LCL. And then for the cruciates, we have a sag sign and posterior drawer for the PCL, anterior drawer and Lachman's for the ACL. Okay, and then we also have rotatory testing. It's probably not going to be on the practical, but rotatory testing would involve trying to put a rotation in. So I could modify anterior and posterior drawer with a rotation, pulling on one side more than the other to test for rotatory instability. But what you need to know for rotatory instability is the sign. What's the sign the patient gives you? Doc, my knee is going like this, okay? What's that called? Hand sign for Dr. Hand, or fist sign for Dr. Fist. They were partners. Okay? They both discovered it at the same time. A hand sign or fist sign, okay, for rotatory instability. And what was the bone of contention here? No? Okay. All right. So that's,
Yes.
yeah.
So the anterior and Lockman's are both the same ACL.
The same ACL. What? Yes. Yes, ACL.
I'm just confused because one is like, I think anterior cruciate or anterior collateral.
There's no anterior collateral.
Thank you.
Yeah, the cruciate's inside. ACL's like this, hands in the pockets. Let me just sit like this for a moment.
You're on camera, by the way. Just to let you know.
Don't post this anywhere. ACL's like this, and the PCL is like this. Okay, they both originate up in the intercondylar notch, and ACL goes anterior, PCL goes posterior, as you showed me in your illustration of the tibial plateau. Okay. Let's go to the meniscus test. So meniscus test. Number one, absolute given on this, you need to be able to find the joint line. Where is the joint line? It is south of the patella and north of the tibial tubercle. Okay, so it's in between the inferior pole of the patella and the tibial tubercle. So you need to absolutely be able to find those. And then what structure runs between them? Patellar tendon. Okay. Some people call it a ligament, but it's a tendon, okay? It is a tendon. If it was a ligament, the knee wouldn't work that well. Ligaments are more elastic than tendons. So we don't need that when you have if it's attached to a muscle, the elasticity can come from the muscle tone. So you want something really stiff attached to a muscle, and that would be a tendon. So I find the tendon, just pinch it, push my fingers in, I can feel the condyles. And then I can feel the tibial plateau, and then I work my way around. And it helps to wiggle the leg to keep your hand on top of the tibial plateau. And you want to work all the way around. Does that hurt? Tell me what about this? What about this? Does that hurt? Oh, okay. And if they have a pain in the joint line, that's an important finding. Because chances are if they have a meniscus tear, they will have that joint line pain. If they have a joint line pain, it does not mean they have a meniscus tear, but the opposite is true for the most part. So if I find that pain, I can try to make that pain do tricks, okay? And the tricks we can make it do, we might be able to make it move back and forth. It's called Steinman's tendinous displacement sign, but what I would expect you to know is the normal movement. So which way does the meniscus move when you extend the knee? Same way as the tibia moves. So that would be forward, okay? And when I flex the knee, it moves back. The other way to think about it, we have little muscle elements that go in and help to pull the joint capsule out of the way whenever you move any joint, right? So the joint capsule is going to tend to get pulled towards the side of movement. And meniscus are really just little tabs inside of a joint, right? We have them in the facet joints in the cervical spine. Or we have them in every synovial joint. They're just huge in the knee. So we can make it do tricks. So the first trick that you absolutely need to know is McMurray's click test. So what I'm going to do is I'm going to, for the medial meniscus, I'm going to put a valgus load on with external rotation. I'm going to hold that, then I'm going to move it around and see if I can find a pop, click, or a pain on the medial side. If I want to do the lateral meniscus, I can put an internal rotation load on. I'm going to feel with my thumb, and I'm putting a varus load, and I'm going to move it and see if I can make it pop, click, or hurt. Okay. So, and if I do, then that's possibly a meniscus tear. The other related test to that is the Anderson's grind test. I'm going to do Anderson's grind. I would start closer to full extension, and then I would wiggle it around. Again, I'd put valgus force on with flexion and varus with extension. Is that okay? Okay, and that could be for either side. So for the meniscus, you want to palpate over the area you suspect and then put forces in. So this is worth 5 points. So if you can come in and you can say, this is McMurray's split test, you can go like this, you can palpate the joint line, I'd say you probably have 2 or 3 points, okay? So that's the critical thing. And then this is going to be secondary, so you might lose 2 points if you don't do this, correct, right? And the idea, if you think about, well, I want to pull on the side, I want to put a tension load on the side I'm testing, so I want to open up the side I'm testing to try to make it pop or click. Okay, so that's McMurray's. Let's see, what other meniscus tests do we have? Can you like face down for a second, please? We've got the good old-fashioned orthopedic test called Apley's compression test, the same Apley who figured this out, scratch test. So you have it at 90, I press down, and then I, does that hurt? Okay. Apley's compression test, and then there's hyperflexion. That hurt? Okay. Those are tests for meniscus. And then I left one orthopedic test out, Apley's distraction. You kneel, you don't kneel on the back of the thigh, but stabilize it and pull up. Does that hurt? Okay, and then you basically go by where the pain is. Wherever it hurts, that structure is possibly damaged.
That was not on the clinic.
Darn it, not on the clinic form, okay. I won't be able to do. Pardon me?
You're only testing us on the things on this form.
That's what I said. I guess I better look at it before I write the test. Okay.
Like palpation stuff, that there's, yeah.
Well, there's not, you know, it's sparse on palpation, right? So you just need to know the anatomy. Things that stick out, big holes, you know, where the ligaments are, where some of the important muscles are. Okay, let's go to the hip. Okay, so we got inspection, palpation, range of motion. There's not much to palpate on the hip, maybe the PSAS, greater trochanter, area of the femoral triangle, which we went over in the lab, area of the gluteus maximus, piriformis, you should be able to find that kind of stuff. And then if I skip posture, I like posture in the hip, so you should be able to look at your patient and determine whether they have anterior tilt, posterior tilt, lateral or right lateral tilt, or left lateral tilt. In other words, be able to do a postural inspection of the hip and then all the joints. ROM, you know, maybe line your back, please. So, perform, please, passive flexion of the hip for 3 points. Is that okay? 3 points, easy 3 points. Okay, that felt, it looked normal. You want me to ask the number too? No. Guess. Okay.
Guess.
That's 90. Okay, and that's half again. 135. Okay. So you need to be in the ballpark on the ROMs for clinic entrance also. If you're, you know, you can't be way off. So take a look at the numbers. You know, do it on yourself and figure out, you know, put out a viable number. Let's go to hip orthopedic tests. So for the hip, we got flexion, abduction, external rotation. Is that okay? Okay, so you're going to look and feel how much flexion, abduction, external rotation they've got. That's also a good position to palpate the femoral triangle if they can tolerate it. The people who have a positive on the test, you can't keep them like that because it hurts. So just keep that in mind. Actually, the people who are going to have positive on the test, you can't even get them in this position, so often you have to go like this, modify it. Okay. What else we got on there? We got Trendelenburg's. That's my favorite test. Let's have you stand up, please. Time to wake up. So if you stand up, yeah, you should stand behind the patient typically. If you feel like they're neurologically compromised, you might have them, you know, against the wall. But otherwise, I'm going to test his right gluteus medius by having him stand on his right leg. So I can have you pick your left leg up, please. Okay. So and then I look for that. Okay, left lateral tilt. Is this just to help balancing? Okay.
Well, I mean, I gotta show
Man
them,
on a
right?
wire. Okay, all right.